does an individual become refractory to a specific drug or an entire class of drugs?
Although there is some cross resistance among classes on the same drug, for the most part, we assume if you are refractory to a drug, you're not necessarily are refractory to all the drugs in that class. That works in somewhat of a hierarchical way. There's not a lot of evidence to support that, but what the evidence allows us to state is, for example, in general, if you are refractory to a first generation of a class, you still can respond to a second or third generation. The same is not true the other way around. So we know, for instance, many patients who have become refractory to bortezomib, Velcade, can respond to carfilzomib. The same is probably not true the other way around, although it hasn't been properly addressed. We know for a fact that patients who become refractory to lenalidomide, Revlimid, can and actually are likely to respond to pomalidomide or Pomalyst, particularly when used in combination with a third agent, and particularly if that agent is a monoclonal antibody.
And in general, myeloma cells, once they've become resistant to a particular drug, they're going to be resistant to that drug. They may not be resistant to that class of drugs because we know that thalidomide is less effective than lenalidomide, which is less effective than pomalidomide, which is less effective than iberdomide. So each one along that IMiD class is more effective, and approximately 30% of patients that were resistant to the prior IMiD are going to respond to the newest, sexier version. Each and every IMiD from Revlimid onward, so if you have Revlimid-resistant disease, you've been on Revlimid, dexamethasone is not working, and you're exposed to Pomalyst and dexamethasone, you have about a 30% response rate. If you're resistant to Pomalyst and dexamethasone, and you get iberdomide and dexamethasone, you have about a 30% response rate. So each one of these improvements in efficacy with a slight upgrade in mechanism of action will lead to clinical responses. 30% of patients will have a significant response. Now, that's not the case for proteasome inhibition, as these are all different companies and different levels of efficacy.
If I progress on one IMiD, proteasome inhibitor, or monoclonal antibody, is it possible to respond to a different drug in the same class?
Now, that's interesting. The short answer is yes, but it depends. And if you're on a combination therapy, and in the old days, if you stopped, and then 3 years later your disease came back, unlike lung cancer, for example, you could revisit the same regimen you received up front and actually have good response. Now that people are on prolonged therapy, it's a little bit different, especially if you're you get a triplet, a proteasome inhibitor, an IMiD, and Dex, get a transplant, and then you're on an IMiD for maintenance, lenalidomide. If you progress, you can increase the lenalidomide, add Dex, but it's not a great response, about 30%. If you add ELO, it might be more. If you add DARA, it's even better. If you add carfilzomib, or if you switch to Pomdex. And so you are able to definitely salvage within the same class. So in other words, patients who've received thalidomide can be salvaged with len. If they've received both, they can be salvaged with pom. It doesn't mean that you can't get that same class. The same thing with bortezomib, because that's the usual upfront one. Now with bortezomib, you can likely be salvaged with carfilzomib, and maybe so with ixazomib. Usually, though, in combination. That's the big thing. We don't do single agent treatment. Occasionally it's a doublet like dexamethasone plus, say, carfilzomib or dexamethasone plus pomalidomide. But it's often combination therapy. Now, the antibodies we're less certain about because daratumumab has now been moved up. It used to be further after second line or third line. It's now being up to first relapse. And so we don't know enough yet as to whether or not, if you become DARA resistant, how that will impact on future responses. Just found that ELO Pomdex has a good track record, and that may be something we'll be utilizing as well. So we have CAR T cells. We have different strategies with other drugs, other pathways that are being utilized. So that was a long answer to yes, it can be done. But there are times when it doesn't make sense to do that. Plus, you have also issues of toxicity. Bortezomib has a lot of neuropathy associated with it. You've had a lot of bortezomib, you still have neuropathy. It may be difficult to reintroduce that back in if you're still suffering from that. It may be time to switch to carfilzomib, still within the same class, but doesn't have the neurotoxicity that bortezomib has. Or you may just go to an IMiD-based salvage or an IMiD plus an antibody plus steroid-based salvage. We do know that IMiDs make antibodies work better, so both ELO and DARA have better response rates when you combine them with IMiD.
If I become refractory to one IMiD, can I respond to another IMiD?
I think patients that fail or progress on thalidomide or lenalidomide can still respond to pomalidomide. I think, in effect, this may have to do with the degree of binding to the target of these drugs, cereblon. It also may, in part, be due to the different effects, slightly different effects that they have on the immune response. But I think in large part it's not completely understood why one or the other permit efficacy. I think something similar is observed with other classes of myeloma drugs as well.
If I become refractory to one proteasome inhibitor, can I respond to another proteasome inhibitor?
Yes, there are some caveats in that it's less likely for a patient to respond to a proteasome inhibitor where dose is very important. So the cumulative intensity of the proteasome inhibitor makes all the difference. Ixazomib is the weakest proteasome inhibitor, then comes Velcade, and then comes carfilzomib. And so at certain doses of carfilzomib, you expect a lot more efficacy than the standard 1.3 milligrams per meter squared of Velcade sub-Q, which is a whole lot more than 2 to 4 milligrams of Ninlaro weekly. So at each level, you have a different effectiveness of each proteasome inhibitor. So if you're getting 70 milligrams per meter squared of carfilzomib once weekly, and then you want to go to 3 milligrams of Ninlaro and think that that will salvage you, that's not going to work. So as long as you're increasing the dose intensity, you have a chance of getting some effect.
If I become refractory to one monoclonal antibody, can I respond to another monoclonal antibody?
I am not aware of any patient who has become refractory to on a Darzalex-based regimen, then responding to an isatuximab-based regimen. Isatuximab is currently not FDA approved, but on any of those clinical trials where any patient has been treated with isatuximab and then gone to Darzalex or Darzalex to isatuximab, I'm not aware that anyone's been salvaged effectively with a different CD38 antibody. That's not the case, and it's much more difficult to figure out with a CS1 or SLAMF7 antibody, elotuzumab, because elotuzumab is always given with an IMiD and dexamethasone, and trying to, certainly you can have a response, and we've seen that with elotuzumab, IMiD, and dexamethasone after failing on a Darzalex-based combination. So those are not clearly cross-resistant. But the number of patients who respond to elotuzumab effectively in the relapse setting is pretty darn small.